Welcome to the Biebel Roundtable discussion of the Spectrum trial results. I'm joining you from London, the site of the 46th Annual Charing Cross International Vascular Symposium, where we just heard the initial presentation of the primary outcomes from the Spectrum trial. I am John Laird, Chief Medical Officer for Medtronic Peripheral Vascular Health, and I am joined by a very distinguished panel, including the two principal investigators from the Spectrum trial, as well as a lead investigator from the Spectrum trial. First, I'd like to introduce Professor Manj Gohel, vascular surgeon from the Imperial College of London and Cambridge University Hospital, one of the co-principal investigators for the Spectrum trial, and Dr. Kathleen Gibson from Lake Washington Vascular, also the current president of the American Vein and Lymphatic Society, co-principal investigator for the Spectrum trial, and finally Dr. Tobias Hirsch, angiologist and phlebologist from Halle, Germany, one of the lead enrolling sites from the Spectrum trial. So we're very happy to have you with us today to discuss the results from the Spectrum trial. And I'd like to start first with you, Manj, if I could. If you could just tell us a little bit about the Spectrum trial, what's unique about the trial, and why is this an important clinical trial?
Yes, of course. Thanks very much, John. So the Spectrum program was a series of clinical trials designed to really evaluate and help us to decide the role of cyanoacrylate VenaSeal closure for patients with superficial venous reflux. It actually consists of 3 different studies. So there are 2 randomized trials comparing VenaSeal with thermal ablation and surgical stripping, which I think we would consider the global gold standards for superficial venous treatment, but also a 3rd prospective observational study to look at the role of VenaSeal closure in patients with C6 disease or leg ulceration. So that's the summary of the program. But a couple of additional points I'd really like to make. So the trial included some unique outcome measures. In addition to all the traditional measures we would expect to measure, we also looked at specific new tools to look at patient satisfaction, both around the procedure, but also later on in their venous journey, and also looking at elimination of extent of superficial reflux. So rather than considering venous closure as a binary outcome, we decided to look at what proportion of the vein was treated. And the final comment I'd make is really just to commend and congratulate all the investigators. This study and this trial program was many years in the creation, and recruitment started in February and March 2020, which is perhaps the worst time to start a global multi-center trial. But the dedication of the investigators and all of the researchers has led to successful recruitment and the presentations that we perform today.
Great, and congratulations to you both as principal investigators for the trial for getting it done, for providing such great leadership, and also thank you for excellent presentations today here at Charing Cross.
Yeah, thanks, John. And again, to review, the 2 trials that we gave results on today were from the 2 randomized trials. So first, VenaSeal versus surgical stripping. One of our primary outcome measures showed that VenaSeal was superior, and that was in the patient experience. Peri-procedurally, VenaSeal was superior to stripping. At 30 days, so status, the procedure's done, how are you doing now? There was equivalency between stripping and VenaSeal. And then a final outcome measure that we looked at was elimination of truncal reflux. So we've talked before in other studies about anatomic closure of the vein. This study, we looked at how much of the diseased vein was actually treated, and there was no difference between stripping and and VenaSeal. Then moving to the VenaSeal versus endothermal ablation study, looking at peri-procedural outcomes, VenaSeal nearly met significance for being superior, but we couldn't meet that quite statistically. And at 30 days, there was no difference in the patient experience between radiofrequency and VenaSeal for how the patient was doing at that time. We found also there was an equivalence in elimination of truncal reflux between those 2 technologies. So that was kind of the gist of what we presented today on podium.
Great. I have to say, in my own practice and my experience, patients who have been exposed to the two procedures, VenaSeal and endothermal ablation, have a strong preference for VenaSeal because you'll avoid a lot of the unpleasantness of the procedure, the tumescent anesthesia, the having to wear compression stockings religiously after the procedure. Were you two surprised that there was not a greater difference shown in patient treatment satisfaction between endothermal ablation and VenaSeal in this study?
So the reason we do clinical trials in a robust, prospective, pre-specified way is to get objective evidence, and that's what we've done. And the satisfaction was better in stripping, and was a really strong trend to being better in the thermal ablation. So in answer to your question, were the results a little underwhelming? Possibly, but we have to remember that the practitioners performing these procedures were highly skilled, highly experienced practitioners, and I suspect in those hands the thermal ablation procedures were done perhaps in a highly skilled way that had better outcomes than perhaps in the real world. But the conclusion is, in that population with very skilled people, these were the results, and I think we are very proud of the design of the study, but I would really highlight the experience of the practitioners.
I think to kind of add on to that, even though this clinical trial we felt applicable to the real world in that, it was done across the globe, patients of all disease states, very similar gender, etc., compared to what we see in clinical practice, we do have to realize that when we select patients for clinical trials, they're volunteering to do that. And they're volunteering to be in a randomized trial where they don't get a say over what they're going to have done. So I do think if we look, and this will come out in the paper, at kind of how the patients tolerated these procedures, they tolerated them very well. So if I were to put them on kind of a bell curve of the patients I see in my practice, they're the ones that would be on the end of, this patient tolerated what I did very well on that end. And I think that that's the nature of people who volunteer to be in clinical trials. They have an optimistic outlook on how they're going to do. So I think that also is maybe part of the difference that you might see in your personal practice looking at these trial results.
And the overall technical success rates were extremely high in both arms of the trial in terms of anatomic closure of the vein and elimination of truncal reflux. So VenaSeal really stacked up very well with the traditional gold standard treatments.
It did, and I think that also speaks to experience and the maturity of these procedures. And we know that both endothermal ablation and VenaSeal, if done correctly, have very high technical success rates.
And what were the safety outcomes that were assessed in the trial? And how was hypersensitivity diagnosed and managed?
Yes. So there was a data safety monitoring board that looked at all the complications. Certainly, we were highlighting outcomes of interest such as thrombosis, phlebitis, and hypersensitivity. So all of the investigators, we had investigator meetings and whatnot ahead of time, were familiar with the diagnosis of hypersensitivity being pain, itching, redness that occurred after the procedure. So these were identified by the investigator. Treatment of the patient was per investigator's own personal protocol. We did not mandate how they were treated. And the rates of hypersensitivity were in line with what we already knew from the literature, both in Asia and in literature from Europe and the United States.
And just if I may, just to add to that, I've been involved with many clinical trials, and the safety adjudication and assessment here was extremely robust. There was an independent committee who adjudicated all potentially relevant events. And so you could say, really, these patients were under a magnifying glass when looking for safety. And it's really to give the world confidence that the VenaSeal is a safe intervention. And I think that's what the trial has shown.
Mm-hmm. I know, Tobias, you're a long-time VenaSeal user and enrolled many patients in the trial. Could you just talk a little bit about your experience in terms of how patients responded to VenaSeal and how they do longer term, and a little bit about your experience with hypersensitivity?
Yes, to be honest, I was not surprised with the results at the end. as I'm treating my patients with both thermal treatment and VenaSeal for more than 10 years. I think the most important issue with this trial is before we start any type of treatment, we have to inform our patients, and we have to select our patients. We have to individualize our treatment plan, and what we need is evidence, and randomized trials is what we need for evidence, and so it makes it easier for us to inform our patients as we have this big trial with a lot of individuals in the study population. For me, it was very interesting that there was one feature in the with the study design that we were not allowed to treat the tributaries in the same initial treatment, which is a good decision to have a comparable study population. And so we asked our patients to think about that 3 months later, when it was allowed to treat also varicosities and tributaries. And what we learned from the trial was that we can wait for the tributaries to disappear by itself. And so this had an influence to our future planning for any type of varicose vein treatment.
A very common misconception about randomized trials is that they give you the answer. Trials don't give you the answer. They give you a lot of useful information and build a foundation on which physicians can then arm themselves and have an armamentarium of different modalities. And I think Tobias is absolutely right about the lack of tributary treatment. And again, it was we treated very, very few tributaries in the patients treated particularly with VenaSeal, and that was very interesting. But I think the clinical success and the safety and the satisfaction outcomes are all really reassuring here.
Yeah. Well, we're just now seeing the very early results from the Spectrum trial here at Charing Cross. There's a lot more to come, longer-term follow-up data come in, and we'll hopefully see some interesting data about the need for secondary interventions between the two groups.
And there is another important issue with the venous TSQ, because varicose vein treatment is always dealing with recurrence. Recurrence belongs to the business, and so we have to prepare our patients that we probably will see them again, and then it's important which type of treatment we choose. If we have a treatment option with a very high patient satisfaction, it's easier for the patient to understand that recurrence can happen, but recurrence is not a problem because the treatment is very gentle, and this is what we learned from the results with the venous TSQ. This is a great new prom. I hope this will, it's a success also for future trials.
Yeah. So Manj, in the U.S. we have this particular situation where we have insurance carriers who will not pay for a VenaSeal procedure because it's considered investigational. What would you say to these carriers or to physicians who still consider VenaSeal investigational?
I don't think I'll ever understand the U.S. insurance system, John. But in answer to your question, look, we have, the first in man for VenaSeal was over 15 years ago. We have a large body of evidence with medium and long-term outcomes that show good clinical outcomes. And you add to that the safety, the robust safety evaluation within the Spectrum trial, randomized trials. And I would really challenge anybody to say that VenaSeal is investigational. It's a robust, well-evaluated, really very well-studied intervention that I think we would all agree has a part in the overall armamentarium for treating venous disease.
Yeah. Anything to add to that,
No, I think that's right. And at this point, the evidence behind VenaSeal is much more robust than the evidence that we had for endothermal ablation when endothermal ablation was accepted as not being investigational, if you kind of look historically. Yeah, I would agree that I think that calling it investigational at this point is not accurate.
What I think we have to decide and have to try and build towards is consensus on what the really good indications are for the thermal and the non-thermal interventions. I mean, look, thermal ablation is a great intervention. It's really stood the test of time, but I think there is a real attraction to a non-thermal option. And we talk about the below-the-knee disease, the nerve issues, the lack of tumescence, compression, etc. So I think there's a real attraction. We need to build that evidence and that consensus as to what the optimum patient selection criteria really are.
And I think that's the other exciting thing about all the data that we have is we're at the tip of the iceberg of what we've presented. There's other things we can be looking at and things that even, the investigators haven't thought of that other people may bring up. Did you look at this? Did you look at that? Yeah. We have the data. Hopefully will be more and more coming out that will help us.
Tobias, I think I know the answer to this question already, but I'll ask it. Did you hear anything today in the presentations that's going to change how you manage your patients with superficial venous disease?
Varicose vein treatment is always a very individual issue, and so we need more than one tool in our toolbox, and the results of this trial give us more knowledge about the advantages and drawbacks of both thermal treatment options and adhesive closure, and so we have more information for better treatment of our patients.
Great. So a final question. I'll ask this question of each of you. What is the one thing that you would want your peers to take away from the data or the outcomes that are presented here from the Spectrum trial? Start with you, Manj.
Yeah, so I think treating venous disease is a journey. We may end up at the same place after 6 months, 1 year, 2 years. But I think the process and the journey is very important. And I think the focus on patient satisfaction, the focus on quick recovery is something I would really want people to pay more attention to. And that's what we really focused on here. And then there are some real signals that the non-thermal approach with VenaSeal is something that may have advantages in that field.
Kath?
So I think that I would want them to take away that the technologies that we have available in our armamentarium right now, both thermal and non-thermal, work well for patients, that the outcomes are good, that the patients are satisfied, that we improve their lives. And I think that that's a key takeaway, is that we really do have good tools to help our patients.
Tobias?
Yes, and it's always important to talk with your patients about recurrence, and then to respect the expectations of the patient to the treatment procedure itself. And this is what we learn from this trial.
Well, thank you very much for this excellent discussion. It was really exciting to hear the first presentations from the Spectrum trial. Really also excited to hear more to come. Longer-term data kind of coming in the next months to years, I think is really going to add to our knowledge base about treatment of patients with complex superficial venous disease. So thank you again.
Thank you, John.
Thank you.
Thank you.